Good afternoon all. Myself Pratibha Pawal, endocrinologist practicing at Aurangabad, Maharashtra. And today we are here at ESICON 2019 and we are here with the leading endocrinologists Dr. Narendra Kotwal sir, Dr. Sambit sir and Dr. Madhukar Mittal sir. And today we will be sharing their knowledge about the different topics in endocrinology. So first I would like to ask Dr. Narendra Kotwal sir, what did you share in today's session in ESICON 2019?
This talk was regarding PPAR receptors. What is the latest in that and what is the future of these ligands, PPAR?
So what do you like to advise in current learning endocrinologist about this topic?
As you know, Dr. Pratibha, PPAR ligands have been in market in use since 2000. Initially it was a troglitazone which was withdrawn from the market because of various liver failure problems. Then came rosiglitazone, then pioglitazone, and we have been using it. You know, there was a problem with rosiglitazone which was withdrawn from the market because of the various heart failure issues. After that, glitazones had gone into disrepute and increase of glitazone had decreased. But we know as of now, glitazones are the drugs which basically target PPAR, as I said, nuclear receptors, which has got varied effects. It has effects on the insulin sensitivity, it has effect on the lipids and various other effects on the atherosclerosis. So these molecules not only decrease HbA1c but have protective effect on cardiovascular disease. To that effect, pioglitazone, which is being used, but only my take for the young endocrinologist would be not to use it in a full dose, but use in the dose of somewhere 75 to 15 milligram so as to have lesser side effects. Other things I will discuss subsequently.
Okay sir. So now we will move to Dr. Sambit sir. What was your topic in today's conference sir?
Today's topic which I discussed was GLP-1 receptor agonists and their recent developments.
Okay.
So I basically discussed about what we know till now about GLP-1 receptor agonist, what is currently evolving and how the future is for GLP-1 receptor.
So how do you compare the previous GLP-1 receptor agonist versus current newer GLP-1 receptor agonist, whether they are more effective, same effective, what is the advantage?
Yeah, actually currently if you see we have 4 or 5 GLP-1 receptor agonists in India currently which is marketed. Like we start with exenatide, then lixisenatide, then liraglutide, then dulaglutide.
Yes.
So it all depends on the frequency and the molecular size and their half-life. So like the current dulaglutide which is once weekly, the most important advantages is the patient compliance. Like you give an injection once weekly and your glucose is controlled and patients are quite happy about that. Liraglutide we call it as a gold standard GLP-1 because it controls sugar, the weight reduction is very good, and it has got other advantages like CV safety and other things are there. The previous GLP-1 are like exenatide which need to be given twice a day. It has got mostly postprandial effect and it induces nausea and vomiting more compared to the newer GLP-1. So the GLP-1 is evolving. Only thing I should tell to the young endocrinologists that as in the guidelines it has been told that GLP-1 comes at a very high on cards in the management of diabetes, so we should also use it in our clinical practice. So we get the benefit of blood glucose control, we get the benefit of weight neutrality, we get the CV safety and other things.
Oh, that's nice. So now we'll move to Dr. Mittal sir. So what was your topic today?
So what I discussed was on alpha beta crosstalk. So the crosstalk which happens between the cells within the islet, predominantly the alpha beta and also the delta and the other cells.
Again I want to ask Kotwal sir, where we have to choose the pioglitazone in Indian diabetic patients where we get the maximum benefits and less of side effects. So how to choose the patient for the pioglitazone sir?
Dr. Pratibha, I would like to tell my other colleagues that Indian patients as compared to the Caucasians are slightly different in the sense that we have more abdominal obesity.
Yes.
The weight may not be more, but we have more abdominal obesity, and as such, Indian patients have more high triglycerides, low HDL. In that sense, this is a very good drug, which is acting not only as an insulin sensitizer, but as a hypolipidemic drug also. So it decreases triglycerides, increases HDL, Of course, it decreases HbA1c, so it has got an effect beyond glycemic control as far as cardiovascular risk factors are concerned. So in that way, this is a good drug. Sometimes in our practice, we find that patients are not controlled with other drugs. Their HbA1c is slightly on the higher side. Basically, it is because of lipotoxicity or because of the insulin resistance. You just add a small dose of glitazone and you will find sugars are having good control. Another plus point of this drug is the durability, sustainability. This has got a durable effect.
Okay, that's right.
I think the glitazone should be given the proper respect in our clinical practice. How
Yes,
we
sir.
have discarded it in between, but again we came to know that it's beneficial, and insulin resistance has to be addressed at any cost.
There are
So
many
what's
myths
our
about the
point?
good drug actually, and we need to overcome those myths and see the advantage of this drug compared to its side effects.
Yeah, this happened with rosiglitazone basically, but we should not discard pioglitazone just for the sake of this.
I'd just like to emphasize, there is a recently one study called result study. The rosiglitazone along compared with the sulfonylurea. In that study, they did not find any increased incidence of heart failure. And in fact, if you see the initial study by Nissan et al., later on when the study was studied in detail, the patients which had a heart failure were in fact given very high dose and they had underlying heart as such NOHA class 2 or class 3 heart failure as such. So if you are using glitazones, one has to be sure that patient is not in class 3 or class 4 heart failure.
Yeah, and it gives you the beta cell protection added on. And
Yes.
Dr. Sambit mentioned about the GLP-1 agonists also. So that is one area which GLP-1 pathways is really helping in protecting the alpha cells and the beta cells in the longer term.
And no, you
really
see,
helps.
we are going beyond the glycemic control as far as the glitazones are concerned. PPAR receptors are present ubiquitously now. Alpha receptors are in metabolically active tissues, gamma receptors are in adipose tissue, and even pancreas, liver also, whereas delta are present all over. You see, these drugs have a role now, especially in NASH. There is no effective drug for NAFLD.
Yes.
Besides the weight reduction, but this drug combination of PPAR, alpha and delta called elafibranor is being used for non-alcoholic fatty liver disease. Besides that, other diseases like for even malignancies, for neuronal protections, these drugs are being used.
Yes, so that means that we should not target only the HbA1c and fasting or post-meal blood sugar, but apart from the glucose control, if this drug is helping us to minimize the other diabetic complications like NASH, this drug should be preferred over the other drugs.
Yes, one can use considering the fact that there are no contraindications.
Yes, sir.
Absolutely. Even GLP-1, I think Dr. Sambit, you want to tell about that? I think they would also lead to weight reduction and help in the
GLP-1
non-alcoholic fatty
actually
liver
just
disease.
one of the best drugs, if I would tell, is probably GLP-1. Even the current guidelines also tell that after 1 or 2 drugs fail, when you are going for an injectable therapy, the first injectable should be a GLP-1 rather than going for insulin. So GLP-1 has come a long way and it has to be properly positioned. And as Sir has told, GLP-1 has shown weight reduction potential, glycemic control potential, and other pleiotropic benefits and CV safety. And now the current dulaglutide, the reverse AWARD 7, has also shown there is good renal protection also. So those things.
And GLP-1 helps in the glucagon pathway, and that is what the overlap was between our talks in that sense.
Yeah.
So GLP-1 suppresses glucagon to a lot of extent, and the DPP-4 inhibitors. So
Sambit, I would like to know from you regarding GLP-1 agonist. GLP-1 agonists which are available in India. As far as CV safety is concerned, what would be your choice in terms of preference? Which one would you like to give to your patient?
Yeah, till now, if someone tells according to categorizing according to the CV safety, then probably the liraglutide
Liraglutide
with
is the first current
leader trial. But the rewind trial, which is for the dulaglutide, which has been recently published in Lancet also, and that has also shown a very good hazard ratio and significant reduction of the MES outcome. So dulaglutide is also good. But regarding lixisenatide, I think Alexa showed a neutral thing rather than superiority in the cardiovascular outcome.
So in terms of the patient, I think patient would be happy to take one injection instead of daily injections.
Yeah.
patient
Once in a
would
week
be happy
would be
even to have the oral one once the oral comes.
And the oral is also coming. So
When you are likely to be expected in India?
actually semaglutide has been approved outside, but here we need to cross the DCGI, and it's the Novo Nordisk prerogative to decide when to launch in India. So we are expecting it maybe next year, the semaglutide will.
I personally feel once that drug will be available in the market, that may be a game changer as far as GLP-1 agonists are concerned.
Because we are moving from initial conventional drugs like sulfonylurea, and then we are moving towards the beta cell preservation apart from the glycemic control.
And in fact, in my talk, actually I had discussed about what is the future of GLP-1, and there was a very nice article by the father of incretins, Mr. Dr. Nock, who has told after 50 years what is going to happen. And they are actually thinking probably the combined GLP, GIP, GIP and glucagon, the combined agonists are actually coming into force, and they will actually will go more than the conventional GLP-1 therapy.
I think point which Sambit made earlier is very relevant as far as the general practice is concerned. If once patient is on the oral drugs, and if you have to, sugar is not under control, if you have to start something, I think GLP-1 receptor agonist is a good choice to start with.
Once a weekly injection.
And there are GLP-1s which provide CV protection, so then why not use
Generally
GLP-1s?
thinking is that insulin should be started, but we have enough data to show that GLP-1 receptor agonist would be a
because
good
at any
choice.
cost we want the glycemic control, weight reduction and CV safety. If we are giving insulin, we are giving only glycemic control, not the weight or hypoglycemia potential. So hypoglycemia is there. So I think there GLP-1 scores more than.
And with probably chronic long-term beta cell preservation.
Chronic
I mean, you have everything which could these molecules could.
So you are basically buying one thing and get 1, 2, 3 free.
Two, three
So,
things upon, yes.
So maybe the future holds a lot added on with these molecules.
Anything, Sambit, would you like to give for the general public any message as far as the diabetes prevention or general thing that they should do not do? Where generally in my talks I have kept one slide, how to stay healthy. It's a very simple thing. I tell my patients, eat less, eat healthy diet, walk more, because we are bipedal human beings. Eat less, walk more, and very important, which is a forgotten fact, is smile more. Eat less, walk more, smile maximally, and last line is live in the present moment.
and sleep adequately so that your stress level comes down.
Stress reduction, sir, most
Yes,
important.
and I think that's very important that sleep, quality of sleep and sleep hygiene is not emphasized in our day-to-day practice.
Yes.
And it's a good idea that we ask about the sleep history from our patients.
Even as doctors we don't ask, and we actually miss many times the disturbed sleep of obesity, sleep apnea and all those things. And previously we were not diagnosing at all. Now with the advent of sleep studies and all, and that is one factor which needs to be addressed completely, otherwise we are not going to do any benefit to the
Apart
patient.
from diabetes, other factors we take the history, the sleep and the stress management, whether the patient is going through any stress which hinders to get the good glycemic control.
That's
that
right.
again needs to be addressed in your day-to-day practice.
Yeah, we absolutely need to target all the comorbidities. There's no doubt about that.
What do we, regarding Sir's talk, I just wanted to ask him, how you place the contraindications of pioglitazone, what the doctor should know actually?
Firstly, one very important thing is that patient's cardiovascular status. Patient should not be class 3 or class 4 congestive cardiac failure. That's very important. Any patient having fragility fractures or low bone density should not be given. Patient having retinal problems, it should not be given. And any history of cancer, especially if there is any urethral and any urinary bladder issues, one should not be given.
Right. Yes. And what about hematuria? How do you
see hematuria? As far as the etiology of hematuria is concerned, one has to look at the age of the patient.
Yeah.
If a younger individual, it is likely to be stone related. But elderly individual, hematuria for the first time, patient requires full evaluation, rule out. Having ruled out malignancy, if at all this drug has to be used, one should be very careful that there is no evidence of malignancy.
In fact, for all the drugs in that sense for diabetes, my teacher, my mentor, Dr. Bansali used to tell you need to know the contraindication first, then the indication.
That
so if
holds
you
to
know
every
where you
person.
should not use it, you know where you should use it actually.
Yes.
Right.
Okay.